Welcome to PAMED Talks, a podcast brought to you by the Pennsylvania Medical Society. I am PAMED President Arvind Cavale, and as part of my presidential initiative, I'm highlighting businesses and partners who are helping independent physician practices thrive in Pennsylvania. Today, we are focusing on one of the most important and promising areas for practice sustainability, featuring the Alera Group. Today, we have Tina Wilt, who has more than 25 years of experience in managing employee benefits plans. And she was also a key figure in creating Central Pennsylvania's first community-owned health plan and has emerged as a leader in the alternative health plan movement. Welcome to the podcast, Tina.
Thank you very much for having me.
For listeners and viewers who are not familiar, let's start by introducing the Alera Group and the type of work you do as an organization and how physician-owned practices across Pennsylvania should know about what they should know about the Alera Group.
Well, thank you very much. Alera Group is a national independent insurance and financial services firm that works with organizations and employers, as well as individuals, to manage risk and plan for long-term financial stability. At a high level, Alera Group specializes in employee benefit programs, property and casualty insurance, risk management strategies, and wealth planning and retirement planning. We adopt what we call a collaborative model, and that is working very closely with our clients to achieve their goals and success when it comes to managing their bottom line and the risk associated with running their business. In the healthcare and physician practice group space, Alera Group supports organizations and benefit strategies that emphasize transparency, informed decision-making, and long-term sustainability, which helps to lead to a better understanding of cost, managing risk, and meeting organizational goals.
That's great. Right. So the long-term sustainability is really the key in this whole conversation, if you ask me, because physicians are sort of tired of dealing with organizations that come and go or don't maintain their values or don't maintain their culture or their promises, etc. So I'm really happy that the Alera Group chose to work with us at the Pennsylvania Medical Society. Right? So
Absolutely.
that's awesome. Right. So as on a personal level, and I know we've talked about all this for a long time, and you and I go back at least 4 years now, right? So on a personal level, working for over 2 decades in this space, what sort of brought you into working on these community-owned health plan or any similar such model that you see in Pennsylvania?
Thank you for the opportunity to talk about this because it's a passion of mine. Employers feel the strain of healthcare costs every day on their budgets, on their people, on their long-term viability. When the system no longer works, advocacy becomes a responsibility. You've got to champion for a better reality. So that's where I see myself. I stand alongside of businesses and I champion transparency, accountability, and common sense solutions that oftentimes do buck up against the status quo. And equally for physicians who are also strained by a broken system, witnessing that strain is also gut-wrenching to me because really physicians, to me, from my perspective, bring the greatest value to the healthcare delivery equation. And really the physician role and the patient care has too often been just mired down with excessive complexities, misaligned incentives, just churn. It's just really it's heart-wrenching to see kind of where everything has gone. And I feel compelled to work to be able to bring positive change to not only physicians, their communities, businesses, and their communities.
Great. Yeah. So the two sentiments that I bring to this office that I hold, and you'll probably appreciate this really well, is our, gratitude because we have the ability and the skills to heal people, and
Right.
optimism. And I think the gratitude part most people understand well in physician community, but the optimism is really hard to find. And truly, that's just a how do I say, an experience over the last 2 decades of kind of hitting walls, bumping into obstacles, inability to overcome hurdles. So, in a simplistic manner, I feel like we as physicians should do well by doing good, right? Towards that goal, how do you think a community-owned health plan fits towards that goal? And also give us an idea as to what you mean by a community-owned health plan. And then we can go into where it fits into the physician part.
Sure. You talk about gratitude, you talk about keeping, fighting the good fight. I hear you say that. Creating positive change requires courage and resolution. Those are two things that I have seen really bode well in this space. Equally important is vision. How do we want to move the ball down the field? Uh, what can we effectuate realistically to improve the model and to improve people's lives, their quality of lives, the outcomes that we so passionately try to deliver every day? That's really near and dear to my heart. I saw this happen firsthand when I was working to build out Central Pennsylvania's first community-owned health plan. Uh, what we did was we created um, increased benefits by reducing or eliminating all out-of-pocket costs for the member, all the while negotiating fair reimbursements to providers who are local and want to, you know, really exercise all of the bloat out of their system so they're not chasing after member claim share. Um, so we're just trying to make it easier and make it more turnkey and make it make more sense for not only the user, but also the deliverer of care. A community health plan is simply a health plan that reinvests back into the communities that it serves. So instead of siphoning profits off to Wall Street, any dividends are reinvested back into businesses and the residents within the community. So it reflects shared responsibility, transparency, and stewardship, where employers and physicians aligned are doing the best that they can for their people, their businesses, their practices, and the community at large. So it's really about embracing the community, doing what's best for our local regions, because we know healthcare is local. We can't just nationalize this whole thing. It is about the community, and physicians, as well as workers, as well as business owners, we're all part of a community that we care about. And we have to figure out a way to be able to reinvest back into our communities by doing the right thing and by not wasting money and by making the right decisions. So the community-owned health plan is just simply that. I know it's kind of an odd way to say it, but it's just giving back to the community.
So in my simplistic mindset, if would it be accurate if I said, as a physician, being just a physician who cares about my patients and who cares about the quality of care I deliver to the patients, as well as, managing their cost of care along with their employers might actually benefit the community at the same time.
Well, right, because, and we'll talk about it maybe in a little bit, I hope we do, is that
Hmm.
the closer that we can put the payer to the physician, the better. So if the employer is the payer, why do we have to go through mounds and mounds and mounds of administrative bloat to get to the physician, to get to the member? My thought is hook hook up those three stakeholders with an architect like myself and get it done without all of the malarkey that has really caused so much um, confusion, frustration, and barrier to care that we see in our system today.
Yeah, I think that the access to care is the number one issue. I mean, people talk about cost and quality metrics and all this other stuff. I think people being unable to access care in their communities is the number one issue. I think that leads to higher costs and it leads to poor quality and all this other stuff. So, yeah, as I think physicians would love that in terms of being able to get their patients in, and patients would love that to come in and see their patient, their doctors, whether it's in person, virtually, asynchronously, etc. I think we have the technologies now to um, connect people to their doctors, or whoever their caregivers are. And I think there's technology, and maybe you can expand a little bit about it, that can also smoothen some of the processes in terms of not chasing down the claims and calling some 800 numbers and waiting online for hours at a time. So would you mind to explain how that works in your situation?
So, really, looking at so when we try to solve for those issues, of course, we're up against a $4 trillion industry that says do it this way or else. But we try to really flip that on its head and say, okay, well, what makes sense for the patient? We've got to be able to not only break down the barriers to care, but create the space where they can form personal long-term relationships with a care advocate, whether it's a primary care physician, whether it's a specialist. That is a fundamental tenet in how health plans can work best. So that has to happen right away. As far as all of the technology that we learned through COVID, of course, virtual, um, telephonic, video, all of that is being leveraged as technology. So I think it's really just getting back to the basics and thinking about what is going to work well. We also rely on our physicians to help steward the financial aspect of the plan by being somewhat of a concierge around cost and quality. So, when there is a really decent opportunity to use independent physicians and practices and med surg, whatever it is, we really like to tap into those so that members understand, maybe they have a high deductible health plan, maybe they have some out of pocket. What is the best way to navigate the care that they're experiencing so that not only does it steward the money of the plan better, but it also helps with budgetability for the patient. So we're taking all of that into consideration when it comes to building out a plan, trying to make it simple, trying to make the navigation of the plan make sense, and then ultimately leveraging technology where possible.
So someone may question, and this is something, we, again, you and I have talked about this.
Right.
ad nauseum. But uh, someone may question to saying that how can you actually lower cost by improving access to care and reducing out-of-pocket costs to the employees, right? So does that make sense? And how does it make sense?
It does. I mean, it's counterintuitive when you think
Right.
about it. It's like, well, how can I get more and pay less? Well, it's all about how you purchase healthcare. It's all about leveraging uh, fair pricing schedules and reimbursements, doing as much as you can at a out of very costly settings. Maybe we can leverage a registered nurse who will absolutely support someone having an infusion in their home instead of in an infusion center. Maybe it's about um, optimizing a prescription drug benefit to where we are leveraging different types of sourcing of drugs.
So as physicians, our goal is to get our patients the most optimal care at the best time. Right?
Right.
What I'm hearing is to say what you're saying is that creating a community-owned health plan would facilitate those attempts rather than going through the conventional status quo
Well,
middleman.
yeah, and what we would do, and what I have done, is create pathways, so folks can follow them, on a voluntary basis. They would always have the safety net of a traditional type of plan design, but there would be things that we could offer for free by steering folks to high quality, low cost, proven physicians and facilities, so that we have some control over cost. So yes, these are things that we use and would make a tremendous amount of difference in the overall cost of a plan. So it's not necessarily about paying the same price for things. It's about who's doing it better, who has efficiencies, who is able to offer a fair and reasonable uh, uh, price point for something, and then being able to bundle all of that together. You've heard of bundled pricing, bundle that together in a way that just makes common sense.
Yeah, that's great. So I know that we had a short survey that the Alera Group was
Mhm.
sending out to our members. So um, I would encourage everybody to um, click on the link that will be attached to this podcast, so you can answer that question. This survey is just a voluntary survey. There is no obligation. It's purely eliciting interest in this movement. So I'd appreciate whoever is watching to answer the survey. So finally, there are a couple of sort of big uh, sky questions. If a practice leader is thinking about this and saying we need to explore this, or what does this mean to us? What are the steps, what are the first couple of steps to kind of make an objective assessment in your mind?
So, as you know, we are going to be a speaker at the summit in June. So, we will have information and subject matter experts there to discuss or answer any questions that anyone has. You, of course, can reach out to myself. I'm at Alera Group, Tina.Wilt at aleragroup.com. And we can investigate, what is possible when it comes to uh, enabling physicians to be able to take back control of not only the way that they practice medicine, but how they bring benefits to their employees.
Great. Finally comes back to my optimism about the future. And, I think there are no plans without optimism. So give me your optimistic take now.
What gives me optimism about the future of independent physician practices in Pennsylvania and community-owned health plans, and what they have in common is restoring the control that and the transparency for employers and physicians, aligning incentives instead of pitting parties against one another, reducing administrative burden and bloat within physician offices, supporting and steering to independent, high-value physician practices, as well as helping employers meet their fiduciary responsibilities when offering health benefits to their employees. Bottom line, physicians and community-owned health plans using direct contracting as a mechanism aligns the economic forces of the care delivery together. So it just makes sense. It reduces friction and it gives employers and physicians an opportunity to link arms and deliver the best care possible for employees and their communities. This is something that traditional health insurance just simply can't do.
I'm happy that in 2026, this is becoming a reality, right? So I've always believed that the stars have to align, and I think that the stars are aligning this year.
I do
And
too.
as we celebrate our 250th anniversary of independence, I think
Yes.
independent physicians should celebrate at the same time that they're really getting into the action of supporting their communities while at the same time helping their patients, as well as extricating or taking the first steps towards extricating their practices out of the clutches of third parties and middlemen who really may not have the best interests of any of these parties in mind. So this has been a great conversation, and I think we will continue this conversation on June 19th when we meet in person. So thank you, Tina, for sharing your expertise and all the work you're doing to support independent physicians. I think I have to say this out again to my fellow physicians that it is very rare that folks in other industries are willing and able to partner with us, and the Alera Group has been awesome. And they have spent a lot of hours working with us to understand our concerns, build on what we think is logical, and we will continue to do that. So thank you again for listening. Thanks, Tina, for joining me today. And to follow along with these conversations and learn more about my presidential initiative, visit our webpage at www.pamedsoc.org/autonomy. Thank you, and we'll talk on June 19th.
Thank you.